Hello friends, today we will discuss another important topic for MRCPCH DCH clinical examination, palpitation. This case is given in history station. Introduction. Palpitation in children often cause concern about arrhythmias, but are frequently benign. Total time allotted in history station is 14, and for discussion another 10 minutes. Marks allotted 10. Now let's discuss a clinical case. A 10-year-old boy with no significant family or medical history experiences 3 spontaneous episodes of palpitation over a few months. His parents are concerned about potential underlying arrhythmia, prompting a referral. First, you need to take the history of present illness. How is the onset? If the arrhythmia is suspected, the onset could be abrupt and abrupt termination. It may happen once in a week or in a month. Duration, it may last for few seconds to minutes. Aggravating factors like swimming, loud noise, wake up from sleep may lead to long QT syndrome. Exertion may lead to catecholaminergic polymorphic VT, and fever may lead to Brugada syndrome. Relieving factors like vagal stimulation, like vomiting, may be associated. Any other association like shortness of breath or chest pain, you need to inquire. Other complications like any syncope or injury are associated or not. Then you need to take important negative history related to cardiac diseases. Then coming to past history. Any past history of seminal episodes or present or not, any known cardiac case like congenital heart disease, cardiomyopathy, any thyroid dysfunction or pheochromocytoma were associated or not, you need to ask. Any past surgical history, especially the cardiac surgery. Any past hospital admission, any ICU admission. What are the investigation done so far? Any blood test like full blood count, use an EASE thyroid function test, or any ECG or Holter have been done or not. If the child is receiving any treatment like beta blocker, you need to ask about the compliance and side effects. Any other drugs like caffeine and methylphenidate may lead to tachycardia, which may have caused the palpitation. Illicit drugs like cocaine may lead to palpitation as well. Any consultant follow-up like any cardiologist or pediatric consultants are associated with the care or not. Then you need to take brief birth history. Immunization history is very important for cardiac diseases. Nutritional history, whether the child is on any special diet or not. Development history, puberty history, any allergy history, and you need to ask about the dental hygiene. Family history of any similar illness present or not. It has been seen long QT syndrome and cardiomyopathies are autosomal dominant. Major cardiac illness present in the family or not, any history of consanguineous marriage, and how is the family dynamics. Then social history. Most of the time the hidden agenda lies here, so you need to take detailed social history. How is the schooling, how is the academics is going on, is there any history of bully which may lead to exertion and stress and loss of school days because of this symptom or not. How is the condition at home, whether the child is getting any education healthcare plan or any such social support or not. How these symptoms affecting the child's life and how these symptoms affecting the family. Then coming to then we are going to discuss the discussion. What are the possible differential diagnosis of palpitation? The first cause, it could be because of arrhythmia. Arrhythmia you need to divide in two parts. It could be a supraventricular or it could be ventricular. In supraventricular, it could be re-entered arrhythmia or WPW syndrome. It could be atrial arrhythmia or it could be because of junctional arrhythmia. whereas a ventricular arrhythmia like congenital heart disease or long QT syndrome. Cardiomyopathies, it could be because of dilated cardiomyopathy, hypertrophic cardiomyopathy, restrictive cardiomyopathy. Physiological, because of the flight fear fever. Autonomic, postural orthostatic tachycardia syndrome. Drugs, methylphenidate and caffeine may lead to palpitation, and illicit drug use like cocaine may lead to palpitation. Endocrine causes are pheochromocytoma and hyperthyroidism. So, what makes an arrhythmia more likely? Key history points. Frequency. If it is happening once in a week or once in a month, it could be. Onset and offsets are likely abrupt, and duration, which may be lasted for a few seconds to a few minutes. If it is gradual in onset and lasted for a long time, arrhythmia unlikely. Triggers like lack of any wake up from sleep, loud noise, you need to inquire about swimming, are associated or not. Or any fever may lead to tachycardia with palpitation or not. Any other associated symptoms and the family history. It has been seen supraventricular tachycardia is most common arrhythmia in children. Abrupt termination suggests arrhythmia, while gradual slowing indicates benign causes. Red flags: syncope, known congenital heart disease or previous arrhythmia, inherited family history of inherited cardiac heart disease, implanted cardiac defibrillator, or sudden cardiac death below 40 years of age. Any pain present or not. Syncope. Syncope due to arrhythmia, often linked to ventricular arrhythmia, is concerning, especially with exertion. It has been seen supraventricular tachycardia rarely causes syncope. Palpitation with syncope require thorough evaluation, while postural syncope may indicate autonomic cause. A history of congenital heart disease, cardiac surgery, or previous arrhythmia. Patients with these symptoms often need further assessment, especially if under regular cardiology care. Family history of inherited cardiac condition or sudden unexplained death under 40 years of age suggests a genetic component. Hypertrophic cardiac myopathy and long QT syndromes are autosomal dominant and warrant cardiac assessment and ongoing screening. Pain. Mild chest discomfort with palpitation is common and usually not concerning. Severe crushing chest pain is unusual. Examination and investigation. Perform thorough cardiovascular examination and 12-lead ECG for all patients, focusing on ventricular pre-excitation, QT interval, ST elevation. In first ECG, it is showing ventricular atrial pre-excitation which is associated with WPW syndrome, showing the delta wave. In third ECG, it is the long QT syndrome, and fourth ECG is showing the elevation of J point, which is associated with Brugada syndrome. Normal finding in blood tests like full blood count, Eugenes, LFT are common, and abnormal results warrant referral to pediatric cardiac specialist. Further investigations like Holter monitoring, event monitors, loop recorders can be used. Holter is used for few days, and event monitor and loop recorders are used for long-term monitoring. Loop recorder has two varieties, one is external, one is implantable. Implantable is implanted in the pectoral fascia. Personal smart devices like smartwatches can also be useful for infrequent uses. If a documented ECG shows no arrhythmia, reassurance can be provided and no further assessment is needed. When to involve or refer to pediatric cardiology? If history suggests arrhythmia, there are concerning features, abnormal cardiac examinations or ECGs, unsuccessful symptom capture, or confirmed arrhythmia. Thank you. I hope you like the channel.